So that's a teenager, that's a 16-year-old man who actually developed blurriness of his right eye 1 month previously. 2 weeks later, the left eye was involved, and then he went to a public hospital. He was... It's not showing. It's not showing. Can we just fix this, please? Okay, that's fine. Thank you. So, blurriness of vision in the right eye 1 month ago. 2 weeks later, he developed similar symptoms in the left eye. He was admitted in a public hospital. He was thoroughly investigated. He had all the bloods done. All the bloods came back negative. The TB testing was still pending. And he was initiated on systemic steroids, 64 milligrams of methylprednisolone. He, according to the history, he improved, his symptoms improved, but they recurred again when they were tapering the steroids and they were down to 24 milligrams. Other than that, he was exposed to hepatitis B, but he was fit and well otherwise. His visual acuity was completely normal, unremarkable, 10/10. He had no AC reaction, normal intraocular pressure, mild vitritis, and that's the appearance of his fundus. So he has multiple... is there a cursor? Yeah, there's a cursor. Multiple, those yellow, creamy, white chorioretinal lesions, which extend from the posterior pole up to the periphery. So this is the fluorescein angiography. Right eye at the top, left eye in the middle, different phases. We can see that there are hypofluorescent areas, which towards the late phases, they become hyper, similar to in the left eye. And that's the ICG. We see plenty, multiple scatter areas, multiple areas of hypo, indicating a full thickness chorioretinal lesion. And that's the OCT. We can see that there is increased choroidal thickness. There is a severe disruption of the outer retina with a disruption of the ellipsoid zone. The subfoveal region is maintained reasonably. That's why the patient still has 6/6, but he is complaining of blurriness and of restriction of his visual field. So at that point, are they, Mark? Press the button.
We've got a young gentleman who systemically seems to be well, an acute bilateral disease. There's not much inflammation, multifocal. It looks like AMPI to me.
Yeah, well,
this is just to go for one differential. I'm a great fan of treponemal disease, and you can get.
Well,
treponemal.
That's 16-year-old though, but it's a reasonable thought. Yeah.
I'll stick. I said disease. There's one difference: is that angiographically you tend to get a very profuse leak in treponemal early, but we see the classic masking and then the hyper. So hyper, AMPI. The textbooks are wrong. It's not a benign disease. This gentleman's lost a lot of vision. His central vision is going to be poor. I mean, his acuity might be good, but it can be a very aggressive disease. And despite steroids, we don't.
Don't you think that? I mean, what about the extent?
Well, it's a spectrum of disease. He's clearly got a very severe case, very acute. Mm-hmm. If this was indolent and the patient perhaps was from the demographics of Asia with high TB prevalence, but you're never going to get TB being so hyperacute. So,
okay, so don't say no more because
and we'll go on.
Now, all those things are probably things that you have to exclude, and they are at the back of they come your mind. And certainly, AMPI is the first thought, although I think it's a bit atypical for me, but with this hypo and hyper and those multiple lesions, this is the first thing that you have to think. What would you do?
Well, I mean, you've hit him very hard with steroids. I'm not sure it's actually active at the moment, because by the time it seems to burn itself very quickly. Immune second-line steroid sparing or something like so. I mean,
it is active. Also,
okay.
Yeah. So it is. There are new lesions.
I think you've ruled out infectious disease. Unless I'm going to hear some horror that this guy makes, likes cows or something, has got Lyme, or I would give him a steroid-sparing agent, I think, or pulse. You could pulse him with IV methylpred or put an Osidex in. I mean,
okay. Well, there's still the quantiferon pending, so we're expecting this. I mean, would you? Because we increased the steroids just to gain some time to
I would do a chest X-ray to make sure he's not cavitating lesions in his chest. The Q Gold. Okay, if it comes back sky high, you're probably going to give him anti-TB therapy and steroids on the presumption that it could be TB.
So the quantiferon comes back and is borderline, and the parents are very stressed. And the patient is reporting that he is continuously losing vision. So you have all this sort of push around you, and
great. Well, you want to demonstrate, is it steroid responsive or not? So did he actually respond to the high-dose steroids in terms of switching off active lesions, or do you see new lesions despite high-dose steroids? I mean, if that's the case, then the TB issue needs to be thought of carefully. But if he responds to high-dose steroids but just gets toxicity, then you've got to replace that with a steroid-sparing or an Osidex in both eyes.
Let me just show you how it evolves. So 1 week later, we have lesions of different age.
Yeah.
And we can see lesions that they fade out.
Yeah. I mean, that's very typical for MP, and it's a bit quick for TB to get new lesions.
But there are still new lesions, though, in the left eye.
Yeah.
So, and there is progression towards the fovea. That's the most worrying thing. Sure. So we decided to start anti-TB. I don't know. I mean, we felt that we couldn't risk,
you can cover TB, and I'd want to know whether there's any TB exposure and what his risk is. You can do a man too before. Well, he's on steroids anyway, unfortunately, so that won't help. There's no harm covering TB, but what's going to switch this process off is some kind of immune therapy, which is either steroid, if it's steroid sensitive, or an additional agent.
But AMPI is usually self-limited, isn't it?
Well, no, that is the thing. The textbooks are definitely wrong. I mean, I've seen I would say 25% of patients lose significant vision with AMPI, and it is not a benign disease. So this, for me, would fit in a severe AMPI process. We've got new lesions. We've got lesions of differing chronology in a young patient who's otherwise systemically well. This is 99% what we would call an AMPI phenotype, full stop. He's just got a very severe spectrum of the disease.
Okay, so just for the sake of the history, this is 1 month later, and there are still new lesions developing. 1 month later, after we saw the patient, 2 months after the first presentation, there are still, from there to there, as you can see, there are new lesions. And I totally agree with Mark that this is probably AMPI, but it's probably the worst end of the ends. And I think that this is probably this relentless placoid choroideritis, which is a variation of AMPI, really, isn't it?
Probably an AMPI variant, I would think. I mean, these are phenotypic descriptions.
This took 4 months to stabilize, and after 4 months, we could see that there are no new lesions anymore. So from there, you can see that the lesion is fading out. From there, and this one. And the vision, at some point, around 2 months, it dropped down to 612. However, at the end of the follow-up, which was about 5 months, we could see that it recovered again, which is quite remarkable, to 6.6. And now we have the OCT to observe all those changes in the outer retina, and we can see that it is severely disrupted there, but it's recovering. There's some sort of, I wouldn't say regeneration, but it's recovery of the ellipsoid. I don't know.
Was he on steroids for that period of time, or he was having steroid therapy?
We tapered the steroids, but he continued the full course of anti-TB. I don't know, why do you think, I mean, how does it recover, the vision? I mean, when it is so severely disrupted and after a while this spontaneous recovery, does it have to do with the photoreceptors themselves or the condition, the underlying condition?
So I don't think you can really answer. We're just going to be postulating whether or not there's just localized edema in the paraphoveal region that's dropping the vision that's reversible. So we see it, but the exact mechanism's unclear. Yeah. So again, it's about this notion of AMPI being self-limiting versus benign. Self-limiting, yes. Benign, no. Self-limiting is that it doesn't keep marching throughout your life, but benign, no. The difficulty is we assume the only thing we can do, we still don't understand the condition, and we still have the association with CNS symptoms. We don't have any good treatment trial, and we do what we can, and exclude other things in the process. But it is in the bad end of the spectrum, and I would have worked this patient up for everything else as you did.
Yeah.
For sure.
Another thing that we don't have to forget is that we always have to I at least always have to check do an MRI, because they tend to develop CVAs at some point. So I think this is something that we shouldn't omit.
Yeah.
Okay, thank you very much.
Okay, thank you. Tough case.